Okay, sorry for the delay. Okay, first of all, I would like to thank Dr. Sharifa and the team for inviting me to speak on this topic, and also for Dr. Loh for your kind introduction. So I have this disclosure. I run this ultrasound-based HIFU center in Makuta Medical Center. In today's lecture, I'm not going to speak on HIFU in general or even other people's results. I'm going to talk about my results. What I have experienced over the last 2.5 months that I've been doing HIFU, and how I think it will benefit women with adenomyosis. Now, I'll start with a case study. This patient, Archie, a 39-year-old lady married for 9 years with no children. She has adenomyosis with severe period pain and heavy menses. She has been admitted for blood transfusion many times before because of this severe bleeding. She saw me in February last year. So when I saw her, I told her that there are only two options actually: hysterectomy or HIFU. It was a globular adenomyosis. It was very difficult for me to do an adenomyomectomy for her. She said that she will wait for HIFU. This was in February last year, and actually we wanted already, the machine was already in Malaysia, but there was a delay in installing. As you know, MCO came and it messed up everything, and we couldn't even bring the engineers from China to install the machine, and so ultimately she couldn't stand the pain, and she actually underwent a hysterectomy. And this is the hysterectomy. It was a large, this is the case, and it was a large uterus, about almost 16 to 18 week size uterus, and I had to go in and do a laparoscopic hysterectomy. Although the advantage was not really adherent, there was no adhesions between the uterus and the what you call as the rectum. It was clean cut surgery. So this year I'm tying up the uterine ascending branch of the uterine arteries on either side, and then doing the colpotomy, and then removing the uterus. And the uterus was quite large because she's also nulliparous, so it was difficult to remove the uterus from the vagina. So I actually had to morcellate it abdominally using a knife, as you can see. So here I'm finishing the colpotomy. So when it's done, it was just too large. I usually use a knife and cut it, and you can see that it was solid all over. It was solid all over. And the adenomyosis was completely involving the whole uterus. There was also a little bit of fibroids, but mostly it was adenomyosis. And so the uterus was removed. Of course, after the surgery, she's very well, but she has lost a chance to have a baby, and also lost the uterus. So this is the whole uterus that was removed. And after that, the vault was then closed. So, I mean, all of you all know about how to perform a hysterectomy. That is not the point here. The point is, could we have saved this lady the uterus in any other way, and maybe even help her to get pregnant? That's where I'm going to come in today. So this is the uterus that was removed. So you can see that the whole uterus was filled with adenomyosis. So there are actually three. When we look at adenomyosis, there are different types of adenomyosis. By ultrasound, we usually call them either diffuse adenomyosis or focal adenomyosis, adenomyoma. But however, this is a very good book. It's edited by one of my friends, which is Dr. Felix Wong from Hong Kong. And if you have a chance to read it, it talks all about all the different types of adenomyosis. But when you start doing MRI, you realize that there are much more to adenomyosis than what we know by ultrasound. There's something called diffuse adenomyosis, something called internal adenomyosis, external adenomyosis, and adenomyoma. And Bazot, in its MRI classification, has divided adenomyosis into all these types from A to K. And if you look at it, it's actually basically there are three different types of adenomyosis. There's something called an internal adenomyosis, it's called an adenomyoma, and another called an external adenomyosis. So these three are internal adenomyosis. That's basically, it's involving the inner part and also the junctional zone. And you know, this is diffuse adenomyosis. Many of you all know what diffuse adenomyosis is. But what is this adenomyoma? What is this, what do you call as intramural adenomyoma? So different types of adenomyoma. They can be intramural. Here's intramural. It could be submucous. It could be subserous. And then there is an entity called external adenomyosis. That's adenomyosis involving the outer part of the uterus. And these are the ones that will, infiltrate into the rectum, and things like DIE that was discussed earlier. And also it can infiltrate into the bladders. So these are different types of adenomyosis. Now, this is important when we are looking at HIFU, because not all the adenomyosis are the same, and the efficacy and the results will depend on the type of adenomyosis we see. The response will be very good, others will not be. So when I look at HIFU, there are actually two different types of patients. The first are those with adenomyosis who do not want to conceive but want to retain their uterus. Now, these are the type of patients that we will be gladly doing hysterectomies. But these are patients who actually want to retain their uterus. And of course, the other ones, the most dreadful ones, are the ones who have adenomyosis and they want to conceive. And I am a laparoscopic surgeon as well as an infertility specialist. And I always, when I see a patient with adenomyosis who want to get pregnant, I tell them, you have the most difficult condition for me to treat, because I can collect eggs, I can create embryos, but your uterus will not be amenable for implantation. And this is the most difficult cases to treat, in both as a laparoscopic surgeon and as an infertility specialist. So for those who do not want to conceive, we have many options. We can give them oral contraceptive pills. We can give them Dynogest. We can put them on Depo-Provera injections. I have a lot of success on patients on Depo-Provera injections. We gave them for years, and then they can even go into menopause with just Depo-Provera injections, and they do fairly well. We can put in Mirena. We can give them intermittent GnRH analog. Of course, the last choice is hysterectomy. If we do hysterectomy, they are going to be well. But for those who want to conceive, then we are in trouble. We can do adenomyomectomy. This will be discussed later, which is not a very good surgery. It's a very difficult surgery. I've always been disappointed by adenomyomectomy because the patients are never happy with me. Or we can give them GnRH analog or Dynogest, and then followed by either spontaneous pregnancy or frozen embryo transport. There are many IVF specialists who, what we'll do is they'll collect the eggs, freeze the embryos, and then they will give the patients GnRH 6 months, 8 months, 9 months, hoping that the uterus will shrink, and then transfer embryo. And I have personally had pregnancies with this kind of patients, but it doesn't happen to everybody. That is the problem. And patients with 16 to 18 week size adenomyosis, this GnRH analog is not going to touch them. So then comes this issue of whether HIFU is going to help this patient. Now, what is HIFU? I'm just going to briefly discuss about HIFU, because I've got many other lectures that goes in depth about HIFU, its benefits, its complications. Here, I'm just going to touch a little bit and then move on to case studies. Now, HIFU is actually focused ultrasound beam to ablate the adenomyosis. So this is how it works. I'll just show you this short video so that you can understand it. Can you hear the sound? Okay, here you can see the ultrasound beam, and it is brought to a tight focus from a distance, and it ablates these lesions. And with these lesions, then the fibroid or adenomyosis is ablated. This is the machine that we have. Is called a JC200, and it has got this what you call as this transducer with an ultrasound beam in the center, and this transducer will then shoot this ultrasound beam into this uterus and then ablate the tissue. So this is how HIFU works. Okay, so we know that there are actually two different types of HIFU. The first HIFU is called the MRI-based HIFU, and two companies that are making it is Philips and GE. And this is how the machine looks. And this is the ultrasound-based HIFU, which the leader is from China, is Chongqing, China. And this is the machine that is called the JC200. Now, I will just briefly talk about the difference between these two, the MRI-based HIFU and the ultrasound-based HIFU. Although we have got the first ultrasound-based HIFU in Malaysia, the MRI-based HIFU has been available in Malaysia for the last, I think, maybe 12 years. It is in University Hospital as well as in USM. So the difference between these two is actually the way the MRI is based. Now, MRI HIFU, the transducer movement is limited by the size of the hole. This is how it is, and this is the transducer, and the hole does not move, and this ultrasound movement of the transducer is very limited. And also the MRI-based HIFU uses something different, which is called a phase array transducer. The advantage of this transducer is that the focus can be moved without movement of the transducer. But the disadvantage is that the focus of the phase array transducer is by 256 small focal points. So the intensity and concentration is not so good. So the power of the machine is limited. As opposed to ultrasound-based HIFU, this is the whole transducer. It's only one, and it's only a single element transducer. So the focus is very small and very intense, and so it's very much more powerful. So what happens in an MRI-based HIFU is that the power is actually lower, and so you have to do sonication for a longer time. Each sonication could be 10 to 20 seconds, which is not very suitable for an organ that moves, such as uterus. And you know that organ, the uterus doesn't sit there; it moves because as the patient breathes, it moves. And so MRI-based HIFU is very good for a static organ like the brain, but it is not good for the uterus, because when we do ultrasound-based HIFU, the sonication time is actually 1 second. We can go 1 second by 1 second. The most we do is 2 seconds. So we can have very, very controlled ablation with the ultrasound-based HIFU. That's the reason why the MRI-based HIFU did not really succeed very well for uterine fibroid and adenomyosis. So what are the advantages of ultrasound-based HIFU? From what I told you, firstly, ultrasound-based HIFU is real-time imaging when we perform the HIFU, as opposed to MRI-based HIFU, which is not real-time, which means that I'm actually looking at the uterus in real time while I'm shooting. When I'm shooting, and then I can see where exactly the shot is. And that is a big advantage of ultrasound-based HIFU. Also, as I showed earlier, the transducers are more powerful and they are larger, and there's better transducer movement. The transducer can move about 12 centimeters on either side, front and back, and also up and down. And also the operating time is also much shorter. We can do a procedure between 1 to 2 hours. This may take much longer, 3-4 hours to 5 hours in an MRI-based HIFU. And what is the most important is a better success rate. We get a higher percentage of ablation. Ablation is measured by non-perfusion volume, which is the area of the tissue that has been ablated. That I'll show you all with some figures afterwards. So we can get a larger non-perfusion volume. If you have a larger non-perfusion volume, then you will have a better ablation of the tissue. So the benefits is that of HIFU for adenomyosis is non-invasive. When shrinkage of adenomyosis occurs, the uterus will be smaller and it will become more amenable to pregnancy. So patients who want to conceive, we do HIFU for the adenomyosis in the aim of ablating part or all of the adenomyotic lesion, and the uterus will shrink, and then it will be more suitable for pregnancy, whether it is a spontaneous pregnancy or it is for IVF. In patients who do not want to get pregnant, then we can do the ablation in a much more aggressive manner in the aim of reducing menorrhagia and dysmenorrhea. For adenomyosis, the success rate for menorrhagia and dysmenorrhea is up to 85%. And patient can start conceiving after about 4 months of treatment. Once the uterus is shrunk, they can start conceiving. And the beauty of it is that because there's no scar in the uterus, the patient can have a normal delivery after treatment because there's no scar in the uterus. So these are the big benefits of HIFU for adenomyosis. So in patients who do not want to conceive, these are the challenges. What are the challenges I face when I'm doing HIFU is that because in a patient who do not want to conceive, we can do extensive ablation. And we can even include the endometrial cavity, and the success rate for reducing symptoms is very high in this patient, as opposed to patient who do not want a patient who want to conceive. The ablation need to be done more carefully to avoid ablating the endometrium. In these cases, the ablation will be limited, and the success in reducing symptom will be lesser, as less energy will be given to the adenomyotic area. So when I speak to the patients, I'll ask them. Some of them they are at the age when they are not sure whether they want to get pregnant. They want to, but the chances are not good. So this is where we explain to them that there's a difference in ablation when you want to get pregnant compared to you who don't want to get pregnant. And also it's important that prior to the surgery, the intestine should not be adherent to the uterus. And because the one of the most important thing is that the HIFU beam should not have any intestines along its path. If there is, then we can't do the HIFU. And this is especially so in patients who have undergone previous surgery, especially if they have undergone previous myomectomy. I'll give you an example. This is one case that came to see me just a month ago. She has got this huge fibroids, and she has been operated twice before, both for myomectomy, and actually operated on her yesterday. And this was the video that I showed. We actually rejected her for HIFU because the bowel was all stuck to the anterior wall, and this is how it was. If there's a lot of bowel on the anterior wall, and if we have done HIFU on this patient, this bowel may be perforated. And this was a very, very difficult surgery, huge uterus, and to do a myomectomy on this patient with all these bowel adhesions. So now I will talk to you all about my experience. I just started HIFU treatment on the 12th of July 2021. This after 1.5 years of waiting. And then I also got my teacher, who is Dr. Huang, who came down from China. She's been with me for the last 3 months. She's leaving I think next week she's leaving. She sits with me to teach me how to do HIFU. And these are the number of cases that I've done. On the last 2.5 months, I've done 47 cases, thanks to all of y'all. Many of y'all have referred your difficult cases to me. And out of these 47 patients, 25 are adenomyosis, 17 fibroids, and 4 patients with adenomyosis and fibroids. So the next 10 minutes, I will be showing you 4 cases just to show how we do these procedures, and then we will take some questions. So this is my HIFU center. This is the whole unit. This is the console where we control the unit. This is the bed where the patient lies, and the patient usually lies facing down. And this is the bowl. The abdomen is sitting in this bowl with some water, when cold water in it, and the transducer is in here. And that's how the HIFU is performed. Now, before I start telling you all about my cases, I want to highlight this paper, which is the sonographic evaluation of uterine volume at its clinical importance. This is a study to actually know what is the normal volume of a uterus. So the uterine volume varies from 15 to 56 centimeter cube in women with normal uterus. In a 12-week size, non-pregnant, benign pathological uterus, it is about 240 centimeter cube. So this is important because afterwards I'll be showing you volumes so that you have some idea of what is a norm. This is another study published in 2018. This person looked at the normal uterine volumes of patients from, of women from 0 to 40 years of age. Now we'll just look at the 40 years of age. This is 22.5th percentile, and this is 97th percentile. The middle is a 50th percentile. So this is a 50th percentile. So at 40 years of age, the 50th percentile is about 81 centimeter cube. And the largest size is 238, and the smaller is 27. So give you some idea of what is a normal volume, uterine volume of a woman. So this is my first case. I will show you all my first case. It's a 38-year-old lady, para 2. She was noted to have adenomyosis just before a second pregnancy. And the adenomyosis started getting bigger during the pregnancy. She was given GnRH analog and then Mirena in 2019. It was increasing in size over the last 6 months. For the last 6 months, it increased from 3 centimeters to 5 centimeters. She started to having severe pain in the left groin and is going down the leg and also on the right side. Periods were prolonged, and she was gaining a lot of weight with Mirena, so she didn't want to have that Mirena in her. So this was actually referred to me by a gynecologist from Kuala Lumpur. And this is what her MRI findings were. There was a large adenomyotic lesion at the posterior wall. This one we can consider it as an internal adenomyosis. There was no bowel adhesion, so it doesn't penetrate through, but it's a typical finding. I think 70% of my adenomyosis patient will have this kind of figure, which is a posterior wall is completely filled with adenomyosis, involving the junctional zone and the endometrial cavity. And this is the adenomyosis. Now, this is what we call as a contrast MRI, which is before we do HIFU, we do a contrast MRI. We take some measurements, and this is the measurements, 6.85 times 9.17 in this sagittal axis, and the axial axis it is 8.72, and we have a formula to calculate the volume of this uterus. So the volume of this uterus is 287 centimeter cube. So HIFU was performed, and this, as you can see, this was done on the 15th of July 2021. She came back to see me just last week, 2 weeks ago, on the 17th of September. And the volume was, as like you can see, this is the ablated area. I don't have an ultrasound immediately after HIFU because I don't do them immediately for all patients. It's quite expensive. And here you can see this is the lesion that we have ablated. This is the lesion we have ablated, and we took the same measurement. It was 8.20 times 4.80 times 6.49. And when we multiply it, it was 133.67 centimeter cube. So this is how it is. This is before HIFU, 287 centimeter cube, and after HIFU, 133.67 centimeter cube, a reduction of 53.4%. And this is quite remarkable. She's already symptom-free, and I'm hoping that this thing will shrink further and she will not require any more medical treatment. And as you can see, the volume is 133. This is not going to become 0. It's going to become probably at the most maybe 80 centimeter cube, because that is the volume of the whole uterus. It's difficult to actually measure the adenomyosis in patients with adenomyoma. For fibroids, we can measure the fibroid and then see complete shrinkage of the fibroid. But for adenomyosis, we have to measure the whole uterus. So this is the first case that I have got an MRI about 2 months after the procedure. In the subsequent cases, I don't have the MRI because they have not come back yet. This is the second case, 40-year-old lady married for 7 years, not keen on pregnancy, severe dysmenorrhea for the last 3 years, heavy periods. And this is what the finding is. It's an even bigger uterus. It's also another adenomyosis, but this was a bit more external adenomyosis. The rectum was involved. There was involvement of the rectum here. And this is the posterior adenomyosis. The MRI was not very good because it was done elsewhere. And so this is when she came back. This is before the surgery. I do something called a 3D ultrasound, and we can actually measure the volume of the uterus. And this is before the surgery. The volume was 112 centimeter cube. This is on the 20th of August 2021. And this is just when she saw me last week. The volume was 68.81 centimeter cube. So after the treatment, this has actually subsided. So the reduction is 38.5%. She's already quite symptom-free. I'll show you a third case. This is a 41-year-old single lady. Adenomyosis for the last 20 years. In 2010, she had a laparoscopic myomectomy done. A Mirena was placed in 2012 and removed in 2016. She was given a GnRH 3 injections and severe dysmenorrhea and heavy menses. And she didn't want to undergo a hysterectomy. Again, this was sent to me by one of the KL gynecologists to see whether I can do something for her. Ultrasound and examination showed the uterus was 16-week size, bulky, thickened posterior wall resembling adenomyosis. It was a small right adenomyoma. And this was the MRI. You can see that this was a 16-week size uterus. The whole posterior wall was involved. This is another internal adenomyosis. Adenomyoma. I think most of you might see cases like this. You can see that its whole area is adenomyosis. And this is post-HIFU. This one, I managed to do the MRI just after the HIFU, immediately the day after the HIFU. This is our ablation because this patient does not want to get pregnant. She's not thinking of pregnancy. So we could do an extensive ablation. We did probably about 70% of the disease was ablated. This is the post-contrast. And this is the volume reduction. She actually came to see me just a few days ago. Yeah, just 2 days ago. This was the volume taken on the 5th of August, just before her surgery. And it was 534.17 centimeter cube. And here, this is done just a few days ago, which is about 2 months later, 193.47, a reduction of 64.3%. She's very well now. We are hoping that this will shrink further, and so she can be spared of a hysterectomy. So the last case is a 43-year-old lady married for 7 years. She's para-0. She had a IVF done in 2017. This patient came all the way from KK, Kota Kinabalu. Embryo transfer was done in 2017. Frozen embryo transfer in 2021, which was not pregnant after this. She has dysmenorrhea. She takes acoxia. She also has heavy periods. And this patient wants to get pregnant. She still wants to get pregnant. So this is adenomyosis. It's not that bad. It is involving the posterior wall. The uterus is just about 12 week size. This is the whole area. This is the adenomyosis. In this case, we had to do the ablation in a much more controlled manner because we want to spare this endometrium. We cannot be too aggressive in the ablation. So we did the ablation just last Tuesday, and is it Tuesday? I think Tuesday. Yeah. This is contrast MRI. This is the contrast MRI showing the adenomyosis here, and this is a posterior wall. And this is the ablation that we done. It's very controlled. We could have done a little bit more here, but it was very difficult to control it because this lesion was going into the endometrium, and this is the ablation done. So these areas are dead, and we hope that this will shrink the uterus at least to half its size, and then the patient could do another IVF, and hopefully she will get pregnant. So in conclusion, adenomyosis is a very difficult problem. I think all of you all agree that this is one of the most difficult problems in our practice. And it is more difficult in patients who want to conceive. And that is what I am in. I've been an IVF specialist for the last 27 years. And this is one of the patients that I usually scratch my head. What am I going to do with these patients? Many of these patients will actually benefit from surrogacy, but that is not available in this country. HIFU can be used in both patients who want to conceive and those who want to have relief of symptoms. Studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 58%, 85%. I didn't show all the data that I have. You can actually see my lectures on my Facebook, or even on my webpage, or even on my YouTube channel. I've got some lectures on how these are, what are the studies. And not all adenomyosis cases are the same. In some, ablation is easy, but in others, it can be difficult. That's why we do MRI, we simulate, and then we give them what we call as a calculated estimation of what our success rate is going to be, because we don't want to over-promise our patients, yet we know that these patients have got nothing else available for them. What can we do for them? We can't, I mean, the other choice is adenomyomectomy, and you know that adenomyomectomy is got its own problem. Especially, I'm always fearful that after adenomyomectomy, I had a uterine rupture if the patient conceives. So HIFU is a good option for these patients who want to retain their uterus. Thank you. I took 29 minutes, and back to you.